Welcome to the fourth class of our ECG course. Today, we will be exploring the normal ECG. For beginners, the normal ECG can be the hardest one to interpret because it requires you to be sure about the absence of any abnormalities. In this video, we'll discuss the basics of the normal ECG and the 3 laws of electrocardiography that you need to understand in order to interpret an ECG accurately. So, whether you're a medical professional or simply interested in learning more about ECGs, you won't want to miss today's discussion. Let's get started. Let's start by discussing the 3 basic ECG laws that are essential to understanding the normal ECG. First law: a positive or upward deflection appears in any lead if the wave of depolarization spreads toward the positive pole of that lead. For example, if the atrial stimulation path is directed downward and to the patient's left, toward the positive pole of lead D2, a positive or upward P wave is seen in lead D2. Similarly, if the ventricular stimulation path is directed to the left, a positive deflection, called R wave, is seen in lead D1. Second law: a negative or downward deflection appears in any lead if the wave of depolarization spreads toward the negative pole of that lead or away from the positive pole. For example, if the atrial stimulation path spreads downward and to the left, a negative P wave is seen in lead AVR. If the ventricular stimulation path is directed entirely away from the positive pole of any lead, a negative QRS complex, called QS deflection, is seen. Third law: if the mean depolarization path is directed at right angles or perpendicular to any lead, a small biphasic deflection, consisting of positive and negative deflections of equal size, is usually seen. For example, if the atrial stimulation path spreads at right angles to any lead, a biphasic P wave is seen in that lead. If the ventricular stimulation path spreads at right angles to any lead, the QRS complex is biphasic. In the cardiac cycle, the P wave is the first waveform seen, representing atrial depolarization. This depolarization is initiated by the spontaneous depolarization of pacemaker cells in the sinus node in the right atrium, and spreads from right to left and downward towards the atrioventricular junction. The normal path of atrial depolarization is represented by an arrow pointing downward and to the patient's left. Lead AVR always shows a negative P wave, while lead D2 always records a positive or upward P wave, due to the orientation of their positive poles. Sinus rhythm is defined by the pacemaker that controls the atria, and not by the presence of a P wave before each QRS complex, or a QRS after every P, nor by a regular rate and rhythm. Sinus rhythm does not have to be strictly regular, and respiratory sinus arrhythmia is a normal variant. When the heart is being paced not by the sinus node, but by the AV junction, called AV junctional rhythm, the spread of atrial depolarization is in a retrograde direction, which is just the opposite of what happens with normal sinus rhythm. The spread of atrial depolarization upward and to the right results in a positive P wave in lead AVR, while lead D2 shows a negative P wave. The polarity of the P waves in lead AVR and lead 2 depends on the direction of atrial depolarization, and this concept is important in predicting atrial activation patterns. By looking at the P waves in leads 2 and AVR, clinicians can determine whether the sinus node is pacing the atria and assess the presence of abnormalities in the left or right atria by examining the size and shape of the P waves in other leads. The QRS complex in an electrocardiogram represents ventricular depolarization and is more complex than the P wave. To deduce the shape of the QRS waveform, the direction of ventricular depolarization must be known, and it consists of 2 main phases. The first phase is a brief and small amplitude stimulation of the interventricular septum, represented by a small arrow pointing from the left septal wall to the right. The second phase involves simultaneous stimulation of the left and right ventricles, and the left ventricle is electrically predominant. In the chest leads, lead V1 shows a small initial R wave, representing the left to right spread of septal stimulation, and a negative S wave, representing the spread of ventricular stimulation forces during phase 2, away from the right and toward the dominant left ventricle. Conversely, viewed from an electrode in the V6 position, septal and ventricular stimulation produce a QR pattern. The Q wave is a septal Q wave, reflecting the left to right spread of the stimulus through the septum away from lead V6, and the positive R wave reflects the leftward spread of ventricular stimulation. The normal ST segment is typically flat on the baseline, representing the early phase of ventricular repolarization. Slight deviations from the baseline may be seen normally, but more marked ST segment elevations may be seen in certain normal individuals as an early repolarization pattern. Additionally, a variant of normal early repolarization pattern can be observed in the right chest leads, where the ST segments are short and the T waves appear to take off almost from the J point. This pattern is not uncommon in normal individuals. It is important to be familiar with these normal variants in order to properly interpret ECG readings. The T wave typically follows the direction of the main QRS complex, which means that if the QRS complex is positive, upright, the T wave is usually positive as well. However, there are some more specific rules about the direction of the normal T wave. For instance, in lead AVR, the T wave is always negative, while in lead 2, it is normally positive. Additionally, left-sided chest leads such as V42, V6 typically display a positive T wave. It is important to note that there are some variations in T wave morphology that can be considered normal, such as T wave inversions in leads 3 and AVR in children and young adults, and flat or biphasic T waves in the precordial leads in young individuals. However, significant changes in T wave morphology, such as deep or asymmetric T wave inversions or tall peak T waves, may indicate underlying cardiac pathology and require further evaluation. In summary, the direction and morphology of the T wave can provide valuable information about the electrical activity of the heart and should be carefully assessed in the interpretation of an ECG. Thank you for taking the time to learn with us today. We hope that you found this 100% online and free ECG course valuable and that it helps you advance your knowledge and skills in this important field. If you did find this course valuable, we kindly ask for your support. Please share this video with your colleagues, subscribe to our channel, and give us a positive evaluation. And if you're able to, please consider donating any amount you can using the link in the description below. Your support will help us continue to provide free, high-quality education to everyone who wants to learn. Thank you again for joining us, and we hope to see you in our next lesson. Before we wrap up, we'd like to let you know that our next class will cover the electrical axis and axis deviation. This is an essential foundation for interpreting ECGs, and we're excited to delve deeper into this topic with you. So be sure to subscribe to our channel and hit the notification bell so that you don't miss our next lesson. Once again, thank you for joining us today, and we hope to see you soon in our next 100% online and free ECG course.